Hello, welcome again to all those who have logged in or joining the California Thoracic Society for another one of our Friday evening educational webinars. First and foremost, thank you all for being here and giving us some of your time as we continue with our series of educational webinars. Today's presentation is titled Dyspnea in COPD, Clearing the Air on Effective Management. So hopefully that's why you're here, to learn all about that tonight. Tonight's presentation was developed by the California Thoracic Society in collaboration with Verona Pharma. Tonight's esteemed speaker is Dr. William Stringer, one of our esteemed past presidents of the California Thoracic Society. Dr. William Stringer received his undergraduate and medical degrees from the University of California, San Diego. He performed his internal medicine residency, chief residency, and pulmonary critical care fellowship at Harbor UCLA Medical Center in Torrance, California. He is currently a professor of medicine at the David Geffen School of Medicine at UCLA and is boarded in internal medicine, pulmonary, and critical care medicine. He served on the CTS Blood Gas Committee and was the California Thoracic Society president from 2010 to 2011. He was also the chairman of the Department of Internal Medicine at Harbor UCLA for 15 years, from 2000 to 2015. He is active in medical education, patient care, and clinical trials research at the Lundquist Institute for Biomedical Innovation at Harbor UCLA Medical Center. His research interests include COPD, asthma, ILD, and long COVID. His wife is an anesthesiologist, and they have 4 adult children. His hobbies include history, cycling, golf, and bluegrass music. He also plays a mean 5-string banjo. At the end of our live presentation this evening, Dr. Stringer will be available for a live Q&A following the presentation. If you'd like to ask a question during the presentation, that's fine. Please go ahead and use that Zoom Q&A functionality, but we'll go ahead and address and answer those questions at the end of the presentation. Thank you all for being here. Thanks again to Verona Pharma, and I now turn it over to Dr. Stringer.
Well, thank you, Jason, and thank you all your folks, party folks, being here on Friday evening. And obviously, thanks, Verona, for helping with the presentation. I'm going to be talking about dyspnea, and as most of you, or some of you know anyway, my primary interest is in physiology and exercise physiology, but dyspnea is one of those very interesting CPETs that come along with unexplained dyspnea. So we'll hopefully make dyspnea a lot more easy to understand after tonight. So I am involved with clinical trials and cardiopulmonary exercise test book, but I also do some data safety monitoring board and speakers bureau, including Verona, which is really my conflict for this. And we're a clinical trials research site, as mentioned, for a number of different companies and as well as the NIH. So this is kind of the overall outview. We're going to talk about dyspnea. We're going to talk about what is the pathophysiology of it, how do you measure it, how do you actually treat it. We're going to take 2 different approaches to that. One's a bronchodilator approach and one's a pharmaceutical approach. And then the holistic management, which, you know, is for me is pulmonary rehabilitation. We've been involved with that for a number of years here. And then we'll take a Q&A. There should be plenty of time for that. So let's start with the burden of dyspnea. And COPD is an important diagnosis to establish, but frequently dyspnea is one of the first presentations. And that has a lot of different ways to be described. It can be described as air hunger, difficulty with breathing, and it's obviously worse with exertion, but it can be present at rest. And it leads the patient to have a description of the symptoms that can be all the way from gasping to heaviness to difficulty breathing. So all those things sort of get wrapped together and eventually get a diagnosis of COPD with spirometry, hopefully. But have to realize that this dyspnea actually increases their risk of COPD exacerbation. So it's important to try to not only understand it, but to try to prevent those exacerbations. So this is a health sciences channel discussion from a patient. I'm just going to play it real quick. Hopefully the audio tone won't be too loud or too soft.
It's coming up real fast, it's just like you drown. You can visualize yourself underwater. And all your air in your body. You need a breath of air.
So there's a lot of different ways that patients describe these. But the important thing is that dyspnea is an important factor to almost all aspects of their life. And despite being on a LABA/LAMA or a LABA-ICS, about 50% of these patients that have an MMRC, and we're going to go over that, the ranking a little bit, greater than 2, still have dyspnea as an important symptom. So LABA/LAMA-ICS may not be the entire sort of solution to dyspnea. And we know that it actually increases mortality risk, anxiety, depression, and it leads to modifications in lifestyle, not only because of the depression and anxiety, but limiting what they do, further deconditioning. And this is one of the things that pulmonary rehabilitation addresses, is this entire spectrum of symptoms and trying to improve not only their functional capacity, but their ability to approach this dyspnea and deal with it in their lives. So this is kind of interesting. We're looking at absolute risk of exacerbations, and this is 1, 3, and 5-year risk. And what you can see is that the MMRC grade, it's from 0 to 4, goes up. The risk of exacerbation goes up with each one of the grades. It also goes up with CAT score, and usually we try to think about a CAT score above about 10. You can see that increases it. And then obviously the gold situation from 1 to 4. But interesting, the eosinophil count, actually, that's 1, 3, and 5-year risk, goes up, but it doesn't seem to change a whole lot with particular eosinophil counts. So we know dyspnea actually does increase utilization of healthcare, and that can be both regular visits and urgent visits, visits to the specialist, pulmonary or allergist, and also hospital-based interactions. So almost all of those go up about 2 times. So dyspnea is actually driving a reasonable amount of additional healthcare costs. And this is one 6-month interval. And then it looks like it was about 46% higher, about $1,700. And obviously the costs weren't cheap, even with low MMRC, but with high MRC, which over the 6-month period resulted in $5,600 worth of cost rather than $3,800. So the pathophysiology and sort of what is dyspnea, I think is fascinating. And it's something that certainly pulmonologists think about a lot, not only in the hospital, but as outpatients. And the American Thoracic Society has done official statements. The most recent one is getting a little long in the tooth now. It's 2012, and the one before that was 1999. So it has gone a little bit past the usual refresh time. And there was actually some pretty amazing people on this committee: Jane Bobo, Peter Cowroy, Donald Maller, Dennis O'Donnell, etc. Some really good people. So anyway, that statement defines it as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. So we know that, as mentioned before, dyspnea goes up with exertion, and it can be described a lot of different ways. But the important thing is it's also additive. So dyspnea sensations can come from a variety of sources, and it can be measured, but it has not only physical interactions with the patient, but also emotional and behavioral. We're going to get to that in a minute. So it's unfortunately a very personal sensation. So that's something that somebody else can put an EKG on them and read their dyspnea. You have to actually talk to the patient and understand their particular understanding and words that they use. So if you think about all the things that actually can cause dyspnea, it's important to sort of start from all the way down in the chest to all the way up in the brain. And so one of the things I think is important to remember here is that all of these, and not only exclusive, but synergistically can actually improve or can cause dyspnea. So remember the chest wall and skin, the vascular receptors in the heart and lung, metaboloreceptors in the respiratory muscles, as well as tendon and muscle spindles, the upper airway flow receptors, airway C fibers as well, what we used to call the J receptors, and then stretch receptors of the lung, chest wall, excuse me, medullary chemoreceptors, as well as the carotid and aortic bodies. Aortic bodies are not as important in humans, but in other animal species, but both can actually detect changes in acidosis and hypoxia and hypercapnia. And then the limbic system, the primary motor cortex, and then the medullary respiratory center, which is really where automaticity occurs and can be affected by a lot of things, including hypercapnia and hypoxia. So all of these, from all the way out in the periphery to all the way centrally, and even the cortical aspects of dyspnea can be occurring in the same patient. So we really want to think about what's driving it, and by understanding better what's driving it, to actually do a better job with treating it. So this is an interesting study. This is in that ATS publication. But these are in normal people now. But what they did was they limited their tidal volume, and they had mild hypercapnia. And they did this functional MRI, and they looked at two areas really that seemed to light up. And they're at the crosshairs there. The insula is the one that's actually at the crosshairs. The amygdala is actually not shown here. But these are the same areas where you perceive pain, thirst, fear, hunger, those kind of, like difficult emotional sensations that are very difficult to ignore. And these areas that were lighting up, as soon as they allowed the tidal volume to be something that they chose, actually went away. So it's a rapid response, and it's a rapid off response with the certain interactions. Okay, so I think it's important when you talk to the patient to use their words and to use the description that they come up with. And so I think it's good to start with sort of an open question, how would you describe your discomfort? And dyspnea, I think, is a word that patients don't use very much. But difficulty breathing is the other one that you can use as sort of a generic term. And then they will probably come up with lots of different ways of doing it. And I think it's not a bad idea to use quotation marks in your note. So is it the urge to breathe? Are they starved or air hunger? Is there something that, the breath doesn't seem to go down all the way, or it's too small, or they just are unsatisfied? And you mentioned that patient earlier, that they've had this feeling of suffocation, being underwater, being uncomfortable. So all of those may actually be the way that the patient describes their symptoms. So hyperinflation is important. It can be both static and dynamic. And when you look at this chronic inflammation and parenchymal destruction, that's what we see in people with emphysematous or chronic bronchitis or both. That leads to airflow obstruction. But hyperinflation and air trapping are very important, separate from gas exchange. So if you look at the normal lung and the normal diaphragm, it has this sort of moon-shaped configuration. But then as the lungs expand, the diaphragm becomes quite flat. So when measuring just regular pulmonary function testing, you can see that the residual volume is high, the residual volume to TLC ratio and the FRC are all elevated. And then during exercise, you can see that that's even has a greater exacerbation or a greater worsening of hyperinflation. And that's called dynamic hyperinflation. So body box, you can measure the static. During exercise, you want to measure inspiratory capacities. And so remember that the time constant for getting air in and out of the lung is the resistance times the compliance. So high resistance is pretty easy to understand. High compliance means it's very, very floppy or non-elastic. So people with chronic obstructive pulmonary disease lose parenchyma, they lose tenting of the airways, and they have a lot of airway inflammation. So there's narrowing, there's loss of parenchymal sort of resiliency of the lung. So the time to get air in and out goes longer and longer, and that causes dynamic hyperinflation as the patient develops dyspnea, an increase in respiratory rate, and even triggering of those central areas of fear or discomfort or the sensation of dyspnea. So all those are important, not only at rest, but during exercise. And you can sort of do this for yourself. If you take a deep breath in, let a little bit out, take another deep breath in, a little bit out. It doesn't take very long to get right up to the top of your lungs, and that's a very uncomfortable place to breathe. It takes a lot of energy to do it, and it immediately sort of gives you the perception of what we call dyspnea or air trapping or hyperinflation. Okay, so if that's what it is, how do you measure it? So the sensory portion of it is usually measured with a Borg scale or a visual analog scale. And it's done both clinically and in research subjects. And during the assessment of dyspnea, you also want to know what kind of impact that's having on the patient's life. So the MMRC gives you an idea of how much that dyspnea or breathlessness is limiting their functional ability, their employment, quality of life, etc. So we're going to go through those real quick. So this is a visual analog scale from not breathless at all to extremely breathless. It's visual, and patients can just mark off where they are. That can be tracked over time. The other one that's very common is the Borg scale. The original Borg was from 6 to 20, and that's because your heart rates in most patients are between 60 and 200. But it's been modified to 0 to 10, and that's easier to understand. The yellow is sort of very light. The green is moderate, and the red is severe. So you can use things like the anaerobic threshold during exercise testing to put the amount of energy that's being required to do a particular ergonomic focus or a particular work rate. And then you can correlate that with the Borg scale as what is the patient seeing at a time when you see this various light, middle, and heavy exercise. So that allows you to put those two together. So this is the MMRC, and what you can see is that grade 4 is really somebody who is too breathless to leave the house. That's not very common, but we do see those. Grade 2, I think, is the one that's important, and it's easy to ask during the evaluation in clinic, is that, do you walk at the same rate as people your age, or do you have to go slower? And so that's a nice break off at 2. And then 0 is basically only strenuous exercise, which is normal in people without heart or lung disease. So grade 2 is an important one to remember. And grade 3 and 4 is getting a high degree of dyspnea. Okay. So the Transitional Dyspnea Index is actually a survey that's administered to the patient. It's done mostly in research, so it's not something you'd do in the clinic. You would probably do either the CAT test or the MMRC. So this one actually is 3 different domains. One's functional impairment, one's magnitude of the task, and one's magnitude of the effort. So those are all scaled from -3 to 3. So what happens is the entire assessment goes from -9 to +9. And when you think about what we call a minimal clinical important difference, MCID, the MCID for this is to change by 1, either up or down. So it helps us understand in a more clinical way the research arena what's going on with dyspnea, but it's not a very common thing that's actually used in the clinic. But it's actually going to be described in a couple of those studies I'm going to talk about. So I just wanted to at least hit that as an important marker. It's used in a lot of clinical studies. So the last one is the evaluating respiratory symptoms, so the E.RS, not as opposed to ERS. And it's 11 item survey, and the scores go from between 0 and 40, and they're broken up again into 3 areas. One's breathlessness, one's cough and sputum production, and the other is chest symptoms. And the MCID for that is about a change of 1 in each one of those categories, or added together, change of 1 as well. So The MCID is again about 1 for this group. Okay, so we're going to talk about 2 different studies and 2 different approaches to improving dyspnea. We talked about this before, that uncontrolled dyspnea is not a good thing for the patient, but it also increases the risk of COPD exacerbations. So we want to actually improve their functional status. We want to make sure that their symptoms are improved or controlled and to prevent exacerbations. So this is the most recent GOLD guidelines for 2025. And these are for people that are naive starting therapy. So it's divided up into people that have low symptoms on the x-axis there. So that's MMRC of 0 to 1 and CAT less than 10. And then on the right side there is MRC greater than or equal to and CAT greater than 10. So those are people that have a lot of symptoms. And the lower rung there is no exacerbations or 1 exacerbations. The top actually is LABA-LAMA related to greater than 2 exacerbations. So, and that also can be considered inhaled corticosteroids if the blood EOs are elevated. So that's the way that this is sort of couched, is that bronchodilators in some form are going to be used to try to treat both low and high symptom individuals. Okay, so we know, and this is a pretty educated group, that LABAs obviously activate the beta receptors and actually bronchodilate. The LABAs, the long-acting muscarinic antagonists, block the M3s and decrease bronchoconstriction. So a little bit different mechanism in those 2. So this is just a little bit of a cartoon about the way that these 2 not only interact with the tissue, but synergize each other. The bronchodilation is coming from the left part of that curve, and the right part of the curve is the blocking that's allowing bronchoconstriction to occur, or bronchoconstriction to be blocked, sorry. So both those are actually additive, and we'll see that in this study in a minute. So the study actually was a phase 3. It was randomized, and it had parallel groups. They randomized 1 to 1 to 1 to LABA-LAMA or LABA, and about 2,500 people. And these people obviously had COPD, older group, and former or current smokers. CAT scores, so indicating that they had a high symptom level and not particularly enriched for exacerbations. And the endpoint really was this trough FEV1 at week 24, but they also had spirometry assessments, which we'll take a look at, and patient-reported outcomes, which is the TDI and the ERS, both which may not be too familiar. So this this diagram's a little challenging, but essentially what they're saying is what the changes for baseline. So let's take this far left. This is the trough FVC, and the trough FVC at 24 hours with just a long-acting beta agonist fell 64 mils, and at the trough value for a LAMA alone was 79, higher than the LABA. And then the highest number actually in this forced vital capacity is 125 mils. That was LABA plus LAMA. So the plus 189 is all the way from the LABA all the way to the LABA-LAMA. And then the plus 79 is from the LAMA to the LABA. Hope that makes sense. So you can go over here to the right in the FEV1. There's not as much change in the FEV1 with LABA. With the LAMA, it's about 56 mils. And then the final one is 122 from the very bottom to the very top. So all of those are important bronchodilator responses. In obviously LAMA and LABA-LAMA were the best. At 24 hours, you didn't have much effect, or you actually had slight reduction in breathing capacity with LABAs. Okay, so what went on with their sensations of dyspnea? Well, if you go over here to the TDI, and remember, TDI improving is going positive. So these are all positive responses, and they're also all above the MCID, both LABA-LAMA, LAMA, and LABA. So, and the responder rate somewhere between 40 and 50% in that group. And then if you look at the ERS, which that's going down is a better score for them, you can see that all three of them went down, but none of them actually reached the MCID of about 1. So improved in dyspnea, but all of them had some effect. It's just that the LABA/LAMA had the greatest amount of effect in both the TDI and the ERS. All right, so Gold actually talks about follow-up treatment for dyspnea. So if dyspnea remains a problem, and remember 50% of people that have that MMRC greater than 50% or on LABA/LAMA still had, 50% of them still had dyspnea. You can do other things. You can change to a different inhaler, a different device, different delivery system. You can escalate non-pharmacologic treatments. And for me, that would be pulmonary rehabilitation. But you can also consider added ensifentrine, and we're going to talk a little bit about that in a study. And then again, as we sort of talked about from top to bottom, really thinking about what it is in that particular person that's causing dyspnea and maybe focus on that particular part separate from any other intervention. Okay, so the phosphodiesterase are interesting molecules. They regulate a lot of cellular processes, but the particular thing that the PD3 and 4s are doing is they're actually changing the calcium metabolism. So they're increasing the calcium efflux out of the cell, they're decreasing the influx, and they're increasing the uptake of the sarcoplasmic reticulum. So what you get is a airway smooth muscle relaxation, and that the myofibrils, the soft the muscle in the actual airway wall is actually being affected. And so that's an interesting effect of the phosphodiesterase inhibitors. So this is a trial where they used that in people that had COPD, and it's a conglomerate of 2 different trials that were both 24 weeks and about 1,500 patients, and they randomized them to either the PDE3/4 inhibitor or a placebo. So this does have a placebo in one of its arms. Very similar study population, older people, FEV1 between 30 and 80%, and smokers. And they could be on either a LABA or a LAMA plus ICS or just no background therapy. But they had to have an MRC of greater than 2. And the endpoint here was at week 12, and that was the area under the curve. So the peak FEV1 was also studied, and then we talked again about TDI and ERS. We'll take a look at those. So this is the area under the curve, and you can see that just for placebo, there was actually a fall at 12 weeks, and there was a gain of about 55 mils relative to 0, and the net gain was actually 90 mils. And the peak FEV1 at week 12 went up about 146 mils from the placebo number. And you can see why placebos are important in clinical trials is that there was an improvement in FEV1 related to just being in the trial, even despite the fact they're on placebo. Okay, so the dyspnea TDI went up again, which is an improvement. You can see it exceeds the MCID, and it does in both categories. And the responder rate's slightly higher in the PD3/4s than it is in the placebo. And for the ERS, those both improved, which is going down, but neither of them actually made the MCID. So it's an important way to think about improving dyspnea separate from bronchodilators. So for me, the holistic management of dyspnea is not too complicated. If you look at the Cochrane reviews, one was done in 2006 and one was done in 2015. They have a tremendous number, well over 60 randomized clinical trials, and they all show benefit. So the Cochrane group just basically said, we're not going to do this anymore. It's nothing that needs to be really dissected out. And their conclusions were we found clinical and statistical improvements in important domains of health-related quality of life, including dyspnea, fatigue, and emotional function. I'm not sure what mastery is, but anyway, in addition, the 6-minute walk improved, and that was a functional measure. So thinking about getting patients to pulmonary rehab is actually very important. Not only does it improve their physical status, but it helps them deal with breathing, nutrition, hydration, using their medications, controlling dyspnea, and using and socializing and getting out and doing things and not being trapped in their house. And obviously, if there's a need for oxygen therapy, they titrate that as well. So could heartily endorse that as something that we should be doing a lot more of. Rehab and pulmonary is really underutilized. So that's pretty much what I wanted to say. I am happy to take any questions you guys have, but the summary really is that the dyspnea is important. It drives obviously the cost of healthcare. It remains a current symptom, even though they're quote unquote optimized with their therapy, and there may be other ways, including pulmonary rehabilitation, to sort of reinvigorate their care so that they feel in more control of their lives and they have improvements. And so as we go through with newer medications, I think it's good to think about how that can be used in your own practice, as well as I mentioned, trying to make sure that the patient is having a substantial benefit from what we're doing. And if not, and still has very high levels of dyspnea, that actually has quite a bit worse outcomes, including exacerbations and quality of life, and that we should address that as a separate symptom, separate from their sputum production and their FEV1, et cetera. So I'll stop there and answer any questions, if we have those in the chat box, or if you want to unmute and talk. I don't know if Jason will let that do that or not, but that's okay too.
Thank you so much, Dr. Stringer. Fantastic presentation. We have an opportunity right now as a community to ask Dr. Stringer any questions that might have come up. Please use the Q&A button at the bottom of your Zoom screen. I did enable the chat function that I will receive messages to that I can pass to Dr. Stringer if for some reason you're having issues with the Q&A. I will note one of the first questions that's come in, someone has asked if it's possible for us to send or share the slides. I'm happy to announce that we will be able to put this full webinar with the Q&A available on our website as an on-demand webinar within just a few days of the webinar ending. So please stay tuned and we'll share that link, or you can come back at any time to the California Thoracic Society website, calthoracic.org, and you'll be able to find Dr. Stringer's full presentation. That said, please feel free to send some questions in. And Dr. Stringer, I see our first question has come in. I'm going to go ahead and read it aloud for the audience and leave it to you to respond. The question is, can you speak to why you think some trials, specifically in COPD, show improvements in dyspnea along with other functional improvements, while others don't? For example, why does dyspnea not always correlate?
Yeah, I think it's a really interesting question, and it's kind of the $64,000 question, because the treating patient's symptoms is super important to the patient. And I think they think less about exacerbations. They think less about their pulmonary function, although some of them are quite tuned into it. But they're very aware of their daily symptoms. They're very aware of their exercise limitations. They're very aware of what they've stopped doing because it causes so much dyspnea. So when we think about our particular interventions, why isn't dyspnea improving? Or in certain trials it is. If you look at that long list of potential afferents causing dyspnea, it's a lot. And assuming that we don't understand the physiology of each one of those areas, the receptors, the stretch, the metabol sensors, that one or the other may be differentially affected by the particular medication or intervention chosen. And so it's sort of like if you're trying to come in at a problem, you're coming in at, maybe you're coming in the south or you're coming in the west, but you're not converging from all the different areas. And something like pulmonary rehab actually hits a lot of those different things. So they're approaching the target from lots of different viewpoints. So they're improving exercise capacity. They're teaching them to deal with dyspnea. They're teaching them to use their medications correctly, so they get the dyspnea benefit of response. So I look at it as that we're only taking account of a few ways to improve dyspnea with some trials, and rehab plus medication, I think, is probably the optimal way to approach these. And even repeat pulmonary rehab sometimes after exacerbations can be really helpful for patients. So I don't have a mechanistic answer other than I think thinking about all those things from stem to stern that can actually cause dyspnea as an importance to talk to the patient about, they've had, chest wall injuries, or are they hypercapnic, or, what do they have a lot of anxiety? And so those things really articulate their perception of dyspnea.
Thank you for that great answer to not such an easy question to answer. Next question queued up. I am interested in your thoughts on the role of ICS in the care of COPD patients. I noticed you mentioned the role of LABA and LAMA.
Yeah, so I think we're trying to refine what we do with inhaled corticosteroids. So I think that we probably overuse them in a lot of patients, and we know that there's downsides of inhaled corticosteroids, including increased pneumonia risk. But we also realize that they have an upside, as they're a great anti-inflammatory, and they're applied right to the airways. So they go to where they need to be, and they have less systemic effects compared to oral. So they have their benefits. The benefits are primarily manifested in people that develop exacerbations. That's why the Gold 25 has the E designation now, and that's where inhaled corticosteroids were most effective. I think the use of inhaled corticosteroids is still important, and I actually think putting all triples into a single inhaler is actually really helped patients with compliance, because compliance frequently is the problem rather than the medication that we've chosen. So I think that's something to think about, as well as making sure the patient's using their medications correctly and not overusing inhaled corticosteroids. And finally, if the patient has not had an exacerbation for a period of time, that might be 1 year, that might be 2 years, it might be something to think about backing off from that. And that's somewhat controversial, but I think it's a good thing to be thinking about and sort of have shared decision making with the patient, so that you talk about, there's risk, but there's also benefits, and continuing without an exacerbation risk may sort of tilt the scale in the other direction. So it's a complicated minefield, I'd say, but it is important, I think, to think about whether they really need it, and is the current therapy encapsulating their symptoms to the degree that they're happy with.
Thank you. Next question. Why is dyspnea an independent risk factor for exacerbations?
Well, I don't know if anybody really knows the answer for that. It's an association. It may or may not be mechanistic. It probably indicates that their disease is not well controlled, because there's persistent dyspnea, persistent symptoms. But epidemiology is not proof positive. So it does increase the risk, and you saw that graph with not only the MMRC but the GOLD score, CAT score, and GOLD category. So all of those seem to track up 1, 3, and 5 years. So it's an observation, and I think when we hear that the patient has persistent dyspnea, we should be thinking about inadequate treatment, or treatment that's not directed at the particular problem for that patient.
Thank you. Next question. What is your take on the impact of supplemental O2 in exertional hypoxemia?
Yeah, so I think the key word in that sentence is are they hypoxic with exertion or rest? And we know that giving people oxygen improves outcomes. either 18 or 24 hours worth of oxygen. So that's known, and that's people that have hypoxemia at rest. People that have hypoxemia during exercise primarily benefit from being able to accomplish what they want to do with using the extra oxygen. Maybe they have to kick up the flow rate or something else. So it allows them to do what they want to do. There's not a great amount of information about whether that actually improves mortality or not, separate from the prior studies were actually done back in the 70s, showing a benefit of oxygen in patients that are hypoxic at rest. So it's sort of an unknown area, or something that hasn't been well developed, and it's a difficult thing to study as well, because the degree of desaturation, other things with exercise is quite variable with patients. Some just continue to go down, some go down a little bit and hold there. And then obviously the degree of hypercapnia affects their ability to develop or not develop hypoxia. So there's an interaction with the different gas exchanges.
Dr. Stringer, I'm going to ask a question that came in through the chat.
Sure.
I'll come back to the questions in the Q&A. The question is, have you done exercise study comparison with the combined LABA/LAMA and the phosphodiesterase inhibitor compared with LABA/LAMA only? There was a paper by Richard Light on the use of morphine for dyspnea and COPD. Could you comment on morphine versus just pulm rehab alone?
Yeah, so there's a couple questions. The first question is, I'd love to do that study. Hopefully Verona will put us to work. To actually study differences in medications, we tend to use constant work rate exercise. So they start at a level and we see how long they can stay on the bike on that particular work rate. And then you administer a medication and you see if that prolongs or doesn't. And then you basically flip the group. So you can see what they do on a LABA/LAMA, you can see what they do on the PDE inhibitors, and go from there. So the study, as far as I know, it might be underway someplace, but I don't think it's been done. It definitely would be helpful, I think, because the phosphodiesterase inhibitors, there are bronchodilators. They actually decrease mucus production, and the PDE4 part of it actually inhibits or reduces the inflammatory component. So they really have all three of those aspects of action in people with COPD. So I think that you would find that it would actually have a real beneficial effect, not only in bronchodilation, but also in airway inflammation and mucus production. So I'd love to see that study. So the second part of the question is morphine. So Richard Light, well, he's the guy that did the Light's analysis of pleural fluids. So he's already sort of immortalized. But he also did a lot of COPD morphine type studies at the VA in Long Beach. And so he actually has a paradigm that I think is important, because dyspnea is certainly reduced with morphine, the perception of dyspnea, and maybe even the breathing patterns and other things. He did show improved exercise tolerance, improved symptoms. The problem is it's not an easy drug to administer. It has a lot of problems with tolerance, and we know that, the whole opioid crisis, it's been really dissuaded from being used for pain as well as other indications. So I would guess that even though it does help, and actually it's been delivered through an epidural catheter as well as systemically, both of those actually do help in terms of dyspnea and exercise tolerance, but it's probably not the long-term solution just yet. We probably need to find the components of that molecule that cause less addiction, cause less central respiratory depression, but still improve the perception of dyspnea and improve exercise tolerance. So I would guess that that's one of the areas that pharmaceutical companies will think about, is can we find a molecule through some of the computerized modeling that might give the benefit without some of the downsides of narcotics. And pulmonary rehab alone, I think, is a much better indication or much better intervention at this point than morphine, but it's not always available, and sometimes it's not handy for patients to get there because they may be too many, especially rural areas, may be too far from a center. And so there's a lot of interest in doing virtual rehab and those kind of things. There's increasing data that it is effective. But it's challenging to administer, and even some of the billing and collection aspects of those interventions has been a little rocky lately too. So I think pulmonary rehab is still the best option now, virtual, but I prefer on-site if it can be done. And then, as we go through the future, we'll see how that ends up in terms of the sort of the practice dynamics.
Thank you for that thorough answer. I'm going to head back to the Q&A. We have 2 more questions loaded up. You might want to take a look at this one as I read it aloud. It's got a few specific details.
Okay.
The question is, what are your thoughts for treatment of COPD hypercapnia without dyspnea with nocturnal NIV? ABGs showed a pH of 7.34, CO2 in the 60s, HCO3 in the 40s, an elderly patient.
Okay, so they want to know about possible interventions in that particular hypercapnic scenario.
I believe so.
Okay, well, if I understand the question correctly, hypercapnia is a big problem because the more hypercapnic you are, the less likely you can be on room air and still maintain your partial pressure of oxygen at 60. So the 60-60 club is about the last people that can actually be on room air. And so this person is very close to that. The nocturnal portion of this is important because when you sleep, actually you hypoventilate. That's normal. Even normal people, your arterial CO2 goes up 4 or 5 torr, and it actually goes up higher in patients that have lung disease. So it's very easy to understand that this person might become progressively hypercapnic and progressively hypoxic during nighttime, with or without actual sleep apnea or central apnea. And so non-invasive ventilation is a great way to try to improve that. A lot of times it can be used at night and doesn't need to be used during the day because the patient's up, alert, talking, those kinds during the day. And it's nighttime when you lose some of the drive to breathe and develop mild hypercapnia. So non-invasive ventilation, I think, is important, trying to monitor to make sure that it's actually effective. It has enough pressure to maintain the patient over time, and the saturation doesn't bounce up and down. So I would say that non-invasive ventilation would be the best way to approach that. With or without supplemental oxygen, depending on how hypercapnic they are, they may have to have supplemental oxygen. So if I guess that's the way I would answer that. If there's another or a more nuanced part of this that I don't understand, feel free to put the second question or the second part of the question in there. But that's the way I'd approach it with titration of non-invasive ventilation.
All right, thank you. Last question that we have queued up here for you. What is your approach regarding assessing for comorbidities contributing to the dyspnea?
Yeah, so I think we tend to think that when people have exacerbations, it's all related to the lungs. And we know that there's arrhythmias, and we know that there's ischemia that can occur, and multifocal atrial tachycardia, subendocardial type ischemia. So cardiovascular ramifications of smoking are just as prominent as the damage in the lung. So I always think about when people are admitted, but even if they're in dyspneic as an outpatient, that there may be a cardiovascular component to that. So that's sort of the ischemia and arrhythmia part of it. But they also have, a lot of them have heart failure with preserved ejection fraction. So their ejection fraction's okay, but their compliance of their ventricle, they have stiff ventricles, they don't fill well. And so when they begin to exercise, they develop elevations of their pulmonary pressures. And so that's another component to think about in somebody that's developing dyspnea with exercise, that it may not all be the lung. It could be arrhythmia, it could be ischemia, it could be the, excuse me a second. It could be the heart failure with preserved ejection fraction or compliance, diastolic dysfunction. And so that's important. I think the amount of sputum production and the amount of airway clearance is important for I think is a sort of a secondary manifestation of their dyspnea. And then the third part of it, I think, is just trying to figure out if deconditioning, which is almost universally present in these people, can be addressed and reversed. And again, pulmonary rehabilitation, I think, is a great way to approach that. But those would be kind of my top three. But sitting and talking to the patient for a little while, I think sometimes can uncover things that we may not have expected. And it's hard to find time to actually sit and talk to the patients these days. But I think that's sometimes the best medicine, including just showing an interest in trying to understand their dyspnea and trying to find a way to improve it.
Dr. Stringer, we have two more questions that snuck in.
Okay.
I'm going to go ahead and skip to the second one first. A little more of a follow-up. How about using morphine for end stage CA, COPD, some end stage cardiac disease?
Yeah, so I think it's important to actually treat end stage, heart and lung disease with palliative care. So I think it's important to separate in your mind that palliative care is trying to improve symptoms. So that could be pain, that could be dyspnea, whatever. Hospice care really says, okay, we're at the end of life. We're going to focus on comfort. We're not going to be going back to the hospital, going to the doctor, adding new medications. So hospice services are really for end of life. Palliative care can be used for somebody who has chronic pain in their pancreas or something. So I think that when somebody is getting to the stage where their heart lung is so dysfunctional that they're very uncomfortable with dyspnea, that certainly morphine is something to think about. But I would do that in sort of conjunction with palliative care. And a lot of hospitals have pain services too, where they actually interview the patient and go over the particular symptom and then administer the narcotics in a sort of regimented fashion, so that there's a good interaction with that patient. So palliative care, I think, is what I would think of if you're already thinking of narcotics. And then using narcotics, I think, is important, but to do that in sort of a structured format with palliative care, pain service, whatever, and then to use hospice as patients reach end of life, but realizing some of the younger folks, they may be appropriate for transplantation, and so thinking about that too, that may not be the end of the road, especially a younger person without a lot of comorbidities.
All right, Dr. Stringer, for this last question, I'll leave it to you to do your best here. Can you rate the phosphodiesterase drugs according to efficacy?
Well, I don't think I'm going to go there. I'll let Verona and those folks take care of that. What I would say is that one of the good things about administering things into the airway is that the systemic effects are minimized. So the delivery of these medications is important. We know that prior phosphodiesterase inhibitors had a lot of GI side effects because of the way they were administered. So I think that the most important thing would be to minimize side effects of whichever medication. And I think that the head-to-head of, just like in some of the biologicals, we don't have good head-to-head data to know which one is actually better. But at this time, we know that side effects can be improved by delivery mechanisms. So I would think more about that at this point, like exactly how is it delivered, and when rather than the efficacy, because I don't think there's a lot of data out there to support that one way or the other.
Thank you so much for answering that question and the dozen that came before them. I'm going to go ahead and answer this last question very quickly for everyone, just to let everyone know that when early next week, we will have this full presentation available as an on-demand educational resource, and it will be available to everyone, whether you are an active or non-active CTS member. You'll be able to find the presentation on the CTS website or on the CTS YouTube channel. And we will do our best to reach out to everyone that registered to let them know it's available.
That's great. Thank you, Jason. Thank you, Verona, and thank you, CTS. It's a great organization.
Thank you so much. I will echo that one more time for everyone, and also be sure that Dr. Stringer knows there have been dozens of thank yous and excellent presentations noted in both the chat and the Q&A. We really appreciate this level of engagement. Ultimately, our goal is to be able to support education for everyone, obviously our members, but the entire community, just as important in this collaborative clinical community. So I echo the thanks to Verona Pharma, and most importantly to Dr. Stringer for being available to all of us. I hope everybody has a safe weekend, and we look forward to seeing you all at a future CTS Friday evening educational webinar.
Thanks again. Thanks, Jason. Thanks all the attendees. Appreciate it.
Good night.
All right.